There's been mixed reaction to the passing of the National Health Insurance Bill by Parliament. It will now be referred to the National Council of Provinces for consideration. That's before it heads on over to President Cyril Ramaphosa's desk for final approval or rejection. We're now joined, by the Deputy Director General at the Department of Health, Dr. Nicholas Crisp. Doc, thank you very much for your indulgence on this Friday. Perhaps let's start with this mixed reaction and actually give our viewers an opportunity to hear what people we've been talking to throughout the week, well, since Wednesday, have been saying. Let's take a look, listen.
For it to be called national, it must be about all of us from the beginning.
Sure.
It should be all-inclusive. So what is being proposed could best be described as a low-cost national medical scheme. The time for that is past, and that would be a dangerous pathway to go on to. What we need is a national health insurance where the president belongs, where the minister of health belongs, where I belong, where the judge belongs, where all civil servants belong, where all South Africans belong. If it is not for all of us, we have no reason to call it national.
We are concerned that if you don't deal with this particular issue of medicine access, selection, procurement, whatever system you're using while NHI is being implemented, that we could have a medicine access crisis in our country.
Doc, so the Act applies to all health establishments, excluding military health services and establishments. The Act does not apply to members of the National Defence Force, the State Security Agency as well. And so if it is a national health insurance bill, what led to the conclusion that some should be excluded?
Hi, Dudu, and good afternoon to the listeners. I was listening to Dr. Letlapi, and I'm wondering if he's even read the bill because he's come to some very strange conclusions. So the reason the Defence Force is excluded is because they have their own hospitals, their own military sick bays and clinics, and they have operational areas where they provide services to their people outside of the country and in other bases around the world and mostly in Africa at the moment. So it's extremely difficult to provide cover for those healthcare and pay for those people who are already provided for through their own hospitals. That's quite a common practice around the world for the military not to be included. The State Security Agency has only 2,200 people, employees, and we don't even know who they are. Many of them have multiple IDs. And it's very difficult to try and include them in this kind of arrangement. So they mostly get their health services through the Defence Force anyway. So that's a small number of people who will be excluded from the bill. Everybody else, including the President, the Minister, me, you, everybody else is amongst the 61 million people who will be covered by the National Health Insurance. It is certainly not a low-cost scheme, as was alluded to by Dr. Letlapi, and I'm not sure where he got that. The intention is to cover everything that the public sector already covers, so I'm not sure that heart valve replacements and cardiac catheterization could be categorized as low-cost. It is intended that we, over time, are all treated as equals in society, and we are treated because we have health needs and not because we have money.
Just on the part of the President, you included him in the pool of you and I accessing the same services. Is he not treated at the military hospitals, even in light of NHI?
Well, he may be treated at the military hospital, but he's still a citizen of the country. He's not a member of the South African Defence Force. He's the one person who is treated slightly differently in the country. But he's on record as having said that he would like to be managed in the same way as everyone else. We need to draw a distinction between service delivery, because this is a purchaser-provider split, and what that means is the fund will pay for our health care, and the service delivery will be provided by both public and private providers. That is, in fact, the reason that the EFF have objected, because they do not want any private provision of health care. So I think that often commentators are confusing the two, and they are making it unclear for the public to try and understand what is envisaged. There's also the impression given that the Department of Health is not busy with any strengthening of the current health system and is not interested in anything else other than the NHI. That's very far from the truth. We have less than 100 people working on the NHI, and we have well over 500,000 people working in the health services. So it is a future framework that we are working towards, and it will take time to implement. And that does not mean that there's not a lot of activity going on to try and strengthen what is happening in the current system. But it's the complications of the current system that make it just so difficult to deal with.
Mm. Okay, so on the document, it speaks of the payment of healthcare service providers, and this is the interpretation of a medical practitioner. Let's take a listen at this.
This is probably the single biggest intervention that we would have in terms of rebuilding this country. It's going to be the biggest fund. It cannot be put under the authority of a minister. People that manage that fund, it should be an independent Chapter 9 institution with the members appointed by Parliament with great public participation. Not dissimilar to the way we appointed judges, not dissimilar to the way the board of SABC is appointed, but it has to be independent institution that does not answer to the Minister of Health, who has responsibilities that might be conflicting with the potential functions of the NHI. The minister is a provider of services. So you can't be a provider and also control the fund.
Your response, Doc?
Yeah, thanks very much. Again, it's Dr. Letlapi. So first of all, the SABC as a board is appointed by Parliament, and I'm going to leave it to you to decide whether that's a successful model or not. Whereas the other 147 public entities are all appointed by, the boards are all appointed by the ministers who are held accountable in the Constitution for their portfolios, and all of them, all the boards, and all the ministers who work on all 147 of those existing public entities all report to Parliament anyway. That's how our Constitution is structured. And all of them have to be audited by the Auditor General and account to the Auditor General in the same way as anybody who uses public funds. So the fact that all our legislation, and I mean all of it, requires that a minister is held accountable does not mean that the minister can interfere. And because there was such unhappiness about it, it has been changed in this, what we call the B Bill, that the minister cannot appoint the board without the approval of the cabinet of the country. One wants to avoid a situation where the Parliament is appointing and is the oversight body, because then you end up with a situation that we have with the SABC. If we wanted it to be a Chapter 9 body, then we have to amend the Constitution, because Chapter 9 is Chapter 9 of the Constitution. And I can't see that happening for a very long time. The minister is not a provider of health services. The Health Act is very clear that that is not the responsibility of the national minister nor the national department. The minister is responsible for the policy of the entire health system of the country, and that is outlined very clearly in the Health Act. And those clauses of the Health Act that refer to the minister and the national department's responsibilities are not amended by the National Health Insurance Bill. So I think one must be careful of mixing and confusing what is actually intended in the National Health Insurance.
Doc, you speak of this taking time to implement, time being a year, 5 years, 10 years, 20 years. What are we looking at?
Yeah, Dudu. So let's take what other countries have done, and they are countries that we talk to. Japan took 36 years. Thailand took 15 years, but I think they're still busy implementing. Others have been at it for 70 years and more. So these things do take a very long time to put in place. Where we are at the moment is we first need an act. We don't have that yet. We may get an act signed into law by Christmas this year, and then we have to start with the processes of implementation. So presuming that we are able to proceed, that would require the first clauses to be brought into law, into operation, so that the president signs that the minister may proceed with calling for nominations for a board, which is what is outlined in the bill. A board needs to be created, a Schedule 3A entity needs to be set up, an administration needs to be created, and the various benefits and benefits packages and costing can commence at that point. Now, obviously, a lot of groundwork has been done. Various things were tested in the strengthening of the health systems in the past years, and my job is to start to put together the administration and understand what is administratively required. But these are fairly long processes. There's no fund, there's no money. The money is currently given to the provincial governments and through the National Department in Conditional Grants. And those monies will be moved only after the entity has bank accounts, people employed to manage the bank accounts, systems to pay providers, providers being accredited, and so forth. So I think I'm deliberately giving you some insight into the mechanics of establishing things like this. It does take time. When I say time, I'm talking to see something significant that impacts on people's lives in the funding arrangements, probably 3 to 5 years, and in the service delivery with proper integration under the funds laws, more than 5 years. However, there are clauses in the current National Health Act which the Minister can use to make certain changes now, and there are some provisions in the Medical Schemes Act which can be used now. And those are being discussed and worked through to see which ones will keep us going in the direction of where we want to go with the National Health Insurance. And you may see changes in those environments long before the National Health Insurance is finally on its feet.
Okay, Doc, as we speak, we're showing our viewers the financial implications for the state section on page 57 of the NHI Bill as found on the Parliament website. So it reads, the fund will be financed in various interrelated phases as determined in consultation with National Treasury. The costing budgeting focuses on practical issues rather than general models. The latest focuses on 3 issues. 1, quality of care improvement program, and it speaks of amounts of 75 million rand, 125 million rand and 175 million rand being considered for potential reprioritization as part of the budget process. 2, establishment of the administration of the fund. Please let us know, is that what you were referring to in terms of you now being tasked to deal with the administration? Does that speak to number 2, which is the preliminary costing being 57 million rand, 145 and 285 million rand. 3, actual costing model. Treasury commissioned a simplified intervention-based costing tool for 2019-2020, which provides simple estimates. And then it goes on to read the full set of interventions cost in the longer term around 30 billion rand an annum. And of course, the words, where will the money come from, have been on everybody's lips since Wednesday.
I'm at a disadvantage that I can't follow the figures and I don't know where you're reading from, but the administration of my branch in the National Department of Health is probably in the order of 50 million, is I think that's what you were referring to. And I have a conditional grant of 85 million to begin to put some of the interim measures in place. These are small sums of money. And this is not the funds. This is getting the branch in the National Department of Health sorted. What we are talking about is moving to the best part of 265 billion rand out of the provincial governments, out of the correctional services, out of the road accident fund and other places, and moving it into a National Health Insurance Fund. It's also moving some of the 277 billion rand that is currently spent in the private sector through different tax arrangements into the National Health Insurance. Now, some of that is already in tax credits, about 37 billion rand, and some of it, about 40 billion, is what the state as employer pays to its employees on the Public Service Act and the Police Act as subsidies to their medical schemes. Those are some of the sums of money that could be moved. So they all have different rules. They all have different laws that govern them. And some of them would be easier to move sooner rather than later. For instance, in the public purse, there's a sum of 60 billion rand, which is direct conditional grants to provinces. Other than 10 billion, which is in capital, the remaining 70 billion could be moved without any changes to legislation at the commencement of a new financial year. So it will take quite a lot of unpicking of these various sources of money to explain how one goes to capitalize the fund to pay for healthcare. But it's not different money from the money that is currently spent by you and by me, either through our taxes or through voluntary contributions to medical schemes.
Doc, very quickly for us, I am being wrapped over the knuckles for time, but what do you say to people who have since come out to say, well, this is nothing but electioneering as South Africa heads on into an election year next year? It's less about the people of South Africa and more around loosening or triggering funds for an election year. Is that a fair assessment?
No, that is absolutely unfair assessment, and people have very short memories. National health insurance has been on the radar for more than 20 years. It's been through a green paper and 2 white papers. It was held up substantially by 2 years of COVID, where it was not possible for Parliament to proceed for a very long time in adjudicating the bill. This is long overdue. If anything, it should have been in place 5 years ago already. This got nothing to do with elections. And if politicians want to use it for elections, that's their problem and not those of us who are trying to build a better health system for the country.
Nicholas Chris, thank you very much for your time this afternoon.